David Hanscom is next, and I've known David since our 2015 conference, and I've really loved watching his journey since then. David is not someone to just carry on doing something that he feels is not going to be beneficial to people, and that's basically why he took early retirement from a very successful surgical career to do this work. And you're now collaborating with lots of different people in different fields, and he loves to share his work. And so I'm introduce you to David Hanscom. And thank you.
Thank you, Georgie. So Georgie did this to me in 2017. She had me follow Howard Schubner, which is always a hard act to follow. So I don't feel good about making Howard look good. Let's put it that way. So Howard, you're welcome. So I'm a spine surgeon. I did complex spine surgery for 32 years. And I just watched people, I was the salvage guy. So I watched people have 5, 10, 15 operations before they came to me. And there's not much I can do at that point surgically, but I was able to get lots of people better from lessons learned from my own personal experience, because I went into chronic pain for 15 solid years. I didn't know what happened to me. Didn't know what the story was. And I was on this bridge in 1990. It was at 10 o'clock at night, this exact spot on this exact bridge, Seattle, Washington, the 520 bridge. And all of a sudden my heart started to race. I became short of breath. I began to sweat, start to feel faint and pass out. And I thought I was having a heart attack. I was 37 years old. It turned out to be a panic attack. It turned out to be the first of many, many panic attacks. And I didn't know what it was. So I thought I was losing my mind, which in retrospect, maybe I was a little bit. And I go, how can I become a fearless spine surgeon and have panic attacks in the same day? So my nickname in high school was the Brick, college, medical school. My attitude was just bring it on, bring it on. And I actually did not know what anxiety was. I was a master suppressing emotions. And I keep trying to tell my wife, I think she's finally starting to believe me, that normal people don't become spine surgeons. I mean, think about it. Why would you want to do this? You're on a delicate cord with big instruments. It's very stressful. And so I was in Honolulu, Hawaii, doing orthopedics. I'd done 2 years of internal medicine first. I had not done a surgical training. Very stressful time. But I remember a woman came out of the orthopedic service my first year with an anxiety disorder. And I'm going, what's that? So I had to go to Harrison's textbook of medicine to look up the word anxiety. I go, okay, fine. Didn't apply to me. But in the meantime, my ears were ringing. I had migraine headaches. My feet were burning, but I didn't have anxiety. So I just kept plowing on, bring it on, bring it on. And in 1990, my stresses were ridiculous. Financial, lots of things were positive, of course, great practice, et cetera. But again, you cannot imagine the amount of stress I was under. Once that panic attack occurred, I could not stop them. I went to psychotherapy for 13 solid years, once or twice a week. That's a lot of psychotherapy. I understand my trauma background as much as you can imagine. I had a very, very abusive childhood, a psychotic mother, rageaholic, chronic pain, drug abuse, and I processed it. It got worse. So you only have to remember this one slide. This is my only goal of the talk today, is this word anxiety. So I thought anxiety was psychological. I spent years with this friend of mine I thought anxiety was the cause of pain. And so, again, talking, it got worse and worse and worse. So basically, anxiety is an activated threat physiology. It actually is the pain. So as a result of stress, it's not the cause. And I'll explain that in this talk. This is all you have to remember. So that has really evolved in the last 6 months. I quit my practice in 2019 to do this full time. I was so tired of seeing people badly damaged by spine surgery, I couldn't take it anymore. Really bad, and it's getting worse. So we're doing bigger operations that don't work. So what happens is that my friend Ray and I sat there for hours and hours and hours and tried to figure out this thing called anxiety. So originally started on the left side of the page as the cause and gradually going, So every living creature has a biological imperative to survive, avoid threats, continue to survive, seek safety to regenerate, but also to pass your gene pool to the next generation. That's it. That's a biological imperative. So you have the input or your circumstances, you have your processing system, the nervous system, then the output's the physiology. So I also been very vocal this last year is that I don't use the word mind-body syndrome anymore. It's a correct term, but it implies that there's a separation in the first place. So consider trying to fly this Boeing jet without a computer. Not going to happen. It's taking the sensory input, gas levels, altitude, airspeed, etc. It processes it, and it flies the jet. So the Boeing jet has about 2 million parts. You cannot fly this jet without a computer. It's just a unit. The human body has 30 trillion cells. The nervous system itself has 80 billion neurons. Each neuron is connected to 10,000 other neurons. So most of the nervous system, by the way, is in the body, midbrain, spinal cord, peripheral nerves. So it's completely intertwined with every cell in your body. It's just a unit response. The key issue here is this thing we call anxiety, this activated threat response. It's automatic, it's hardwired. It is 1 million times stronger than your conscious brain, 1 million times. Your unconscious brain processes about 40 million bits of information per second. Your conscious brain processes 40, 1 million to 1 ratio. So picture trying to stop this dragster, which has 11,000 horsepower, with bicycle handbrakes. Not going to happen. You can't control it. So when our cat, then a kitten, was 6 weeks old, my wife decided to take her to a friend's house to introduce her to a neighbor cat. So notice what she looks like. Her eyes are wide open, her hair's on end, her ears are back, her tail is down, her back is arched. So what's going on? It's a whole body reacting to a threat. So cats aren't that social. We've learned that this cat is not social at all. Maybe this is part of her ACE scores, honey. So anyway, your body reacts to the environment in a way to survive. So consider this car, and this is where medicine, I don't want to rant too much today, but all of us learned this in high school. Fight or flight versus rest and digest. So under threat, your body reacts, adrenaline, cortisol, fight or flight. We know this. Somehow, almost every symptom in your body, probably 90%, are a result of your body's physiology. So consider this car. It's parked. It has no symptoms. It's just a structure. Now you have to turn the car on. Maybe it's tuned up. Maybe it's not. Maybe it's missing a spark plug. Maybe it's not really working very well. But you have to turn the car on for the car to have symptoms. That's the physiology of the car. In medicine right now, we're treating 90% of disease as structural. So by the way, we're talking about chronic disease today from my perspective, not chronic pain. Chronic pain, of course, is one of those, but I'm talking about disease states. So I wanted to get rid of the word anxiety. I will still use it in the talk, but basically try to get rid of the word anxiety, just say activated threat response or activated threat physiology. Okay? 1 million times stronger than your conscious brain. It is not primarily psychological. So basically, it's your body's neurophysiological response to threats. It's automatic, it's hardwired, and it's a survival sensation. It's supposed to be unpleasant. It's never going to be pleasant. That's not going to happen. And it's not controllable. You have no say. So consider 4 levels of threat responses. So the nociceptive system, by the way, is not just acute pain. I mean, you stub your toe, that's called nociceptive pain, except the way the body's evolved, you're guided to act in a way that keeps you safe. See, I'm not staring at bright lights. Wow, that was not good. So we don't look at bright lights, we shift in our chairs. That's what the nociceptive system does. It keeps us out of pain. So when we have pain, it means we exceeded the limits. So then we have a response. So you touch a hot stove, you pull away, look at the bright light, bad mistake again, and you have a response. But what happens when that threat is sustained a little bit? You start getting symptoms, and when it's prolonged, you start getting diseases, and again, including chronic pain. So when I was at the worst part of my journey, and by the way, Howard knows this story very well. In 2009, he was a keynote speaker at a course I put on called A Course in Compassion, Empathy in the Presence of Chronic Pain. So Howard started listening to all these symptoms, and I'm going, huh. So I started counting them. I had 17 of these things. So my wife goes up and goes, I have a friend of mine who has these symptoms. And Howard looks at her and goes, you mean your husband? So I had migraines. I had ringing in my ears, burning sensations, of course, panic attacks. I couldn't sleep, extremely depressed, I would say suicidally depressed. I mean, I had all these things, but nobody could tell me what was going on. I'll tell you right now, they're gone, every one of them. They've been gone for 20 years, and it wasn't that hard. And Howard gave an eloquent talk about none of this is very hard. Once you understand the problem, it's a solvable problem. So what happens when Sarno talks about being trapped? And Howard knows that this trap is a big trap. This is St. Andrews, and I would never get out of this sand trap. So you have something that causes anxiety. Let's say it's societal threat, poverty, bad relationships, etc. Your threats are sustained. You can't get out, you're trapped. Of course, pain traps you. So your body comes to you, really fires up, and you become angry. Dr. Sarno called it rage. So then what happens, you're really fired up, and guess what? We know that stress kills you. You know that chronic stress is a killer. So this is a Holmes-Rahe Life Stress Inventory. It was first published in 1962, University of Washington. We've known about the scale for a long time, and don't try to read it, but do go to stress.org and look this up. And it's things like death of a spouse, divorce. By the way, Howard, retirement is number 10 on there, so be careful there. We talked about that last night. So these are stressful life events, positive stresses, negative ones. If you have 300 points on the scale, you have an 80% chance of a major illness within 2 years. So a friend of mine in Seattle has been heavily, I'll use the word persecuted, by the hospital. His stress score was 462. He has a lymphoma of his spine. Another friend of mine, severe stresses, 52 years old, prostate cancer. I mean, you all think about this. Think about your friends with major illnesses. What was their life like before they got sick? This is well-documented data. So, what happens, both at the genomic level, expression of white blood cells, but also the mitochondrial level, which are little engines in each cell, that all these disease states have been linked by a common cause. Cancer, atherosclerosis, depression, osteoporosis, asthma, AIDS, Alzheimer's, dementia, diabetes. So I can show you paper after paper after paper that shows these are hypermetabolic inflammatory states, every one of them. And the literature is getting deeper. Now, a lot of this technology didn't come around until the last 20 years. It's not in clinical medicine yet. That's why I'm here. That's why we're all here, because this is a solvable, preventable problem. So this is a busy slide. I'll spend just a little bit of time with this paper. I thought it was the best summary paper of what I'm trying to talk about today by David Furman in a group. And what they did, they looked at a process called systemic chronic inflammation. So here's the difference. So we all need acute inflammation to survive. So you have an inflammatory response, the tissues are dealt with, you heal. So it's called PAMPs, which are infections and viruses. Your body also has products called DAMPs, where you have foreign bodies coming into the system. You have acute inflammation, solves a problem, it resolves. So the duration is short, it's a high-grade response. The outcomes are healing. Okay, is it age-related? No. The biomarkers are inflammatory cytokines called IL-6, TNF-alpha, etc., C-reactive proteins. So this is necessary for survival. But with systemic chronic inflammation, you have this persistent, not resolving, low grade. It damages your tissues. Is it age-related? Yes, but it's silent. So I don't have the time today to talk about this, but at the mitochondrial level, you have a little molecule called ATP. It's supposed to be in the cell. When it goes outside the cell, it's highly, highly inflammatory. There's no test for that. So again, the disease is linked by this process in this paper. Again, same list. Cancer, diabetes, autoimmune disorders, neurodegenerative disorders, etc. These are all linked by the same common pathway, of course, including chronic pain. So what are the causes? So I list a few. Let's talk about threat for a second. So poor diet, obviously, highly inflammatory. TV has been shown to actually increase inflammatory markers. There's a major study out of Australia on 9,000 patients that showed inflammatory markers were related to the duration of watching TV and early mortality, just from time watching TV. Chronic psychological stress, highly documented to be a factor, of course, toxins and infections. But then the sickness behaviors, why? So remember, there's fight or flight, your body's activated, then you have freeze and faint. So you hit the freeze, faint phase, you lose your energy, you're sad, you withdraw, blood pressure changes, your intake is down. So again, it's a total body reaction to chronic threats. So threat is inflammatory destructive, supposed to be. Threat state, I mean. And it's also hypermetabolic and what we call catabolic. However, and this is for humans, this is a much bigger problem. The heaviest burdens that we carry are the thoughts in our head. Okay, now think about that. We actually all know this. So it turns out these obsessive thought patterns are a huge, huge issue. So Dr. Eisenberger out of UCLA documented that emotional pain shares the same brain circuitry as physical pain. You get the same physiological response. So obviously in the left we have domestic violence, which unfortunately is high in our country. But thoughts are the biggest threats. Why? You cannot escape your thoughts. So I call it the curse of consciousness, that we know emotional pain is processed the same way as physical pain. So you say, you hurt my feelings, of course you did. You broke my heart. So we don't like pain, so what do? We suppress it. Why wouldn't we? We don't want to feel the pain, so we suppress it. Turns out that suppressed emotions are a bigger problem than expressed. It actually shrinks the hippocampus of your brain. That's your memory center. So I'm going to read this twice. So this is out of Chicago. This is the current definition of chronic pain. We propose that chronic pain is the consequence of plastic changes in the cortical limbic circuitry. In other words, the neocortex and the fear system, leading to new learning and to memory formation that are continuously reinforced and thus cannot be extinguished, as a consequence of the emotional and motivational associations with a painful stimulus. In other words, you have a painful stimulus that gets connected with more and more different memories, and it becomes more and more complicated, and you can't get rid of it. The brain works by connection, works by memorization, works by linkages, so these become permanently memorized circuits, hence phantom limb pain. So we know that mental distress translates into threat physiology and creates physical symptoms. But of course, your physical symptoms are unpleasant, they're stressed out, so that fires it the other direction. So I gave a talk in Florida with one of my CBT therapist friends, and we realized that she actually cannot treat physical pain or physical symptoms without addressing the mental component. So as one of my friends says, it's all the same soup anyway, but for humans, thoughts are a major problem. So let's go into the input again. You have your input or circumstances, you have a processing system, and you have your output, which is the physiology. So where's Liz? Can you read this for me, this Scottish phrase? I'm going to try it once. I'll let you read it. To enjoy yourself, that's the thing, and beware the quicksand of perfection. How did you say it in Scottish? Can you say, is there a Scottish accent to that? So this is from Shivas Irons. How many of you read Golf in the Kingdom by chance? Anyway, Shivas Irons is this legendary character. He's sort of the guru of golf. And there's lots of wisdom from his book, but his was, enjoy yourself, that's the thing. And beware of the quicksand of perfection. Did I do that pretty well? Okay. So basically, we're trained to survive. We're not so trained to enjoy ourselves. I mean, where are we programmed in our training? We're self-critical, we're criticized, we're told this, and this, should do this, shouldn't do this, but we're really not trained to nurture joy and play. So going to the input part of it, there's one paper, just talks about the allostatic load and its impact on health. Okay, I'm going to read these also carefully. The presence of a kernel, so there's two criteria, A and B. So the presence of a current identifiable source of distress in the form of recent life events and or chronic stress. The stressor is judged to tax or exceed the individual coping skills when its full nature and full circumstances are evaluated. Okay, stress, right? We tend to think stress is psychological. It's just your, let's use the word allostatic load. Then criterion B, this goes with Howard's talk, the stressor is associated with one or more of the following features, which have occurred within 6 months after the onset of the stressor. At least 2 of the following symptoms: difficulty falling asleep, restless sleep, early morning awakening, lack of energy, dizziness, generalized anxiety, irritability, sadness, demoralization. Number 2, significant impairment in social or occupational functioning. 3, significant impairment in environmental mastery, feeling overwhelmed by the demands of everyday life. So in other words, when your stresses or overwhelm your coping skills, you become sick. We talked about nociceptive pain, nociceptive system, the response, symptoms, and disease. So let's look at the nervous system. So this is a great review paper. It's very advanced. I only understand about half of it. So he goes right into the neuroscience of immunology and inflammation, and he found out there's 4 factors that determine levels of inflammation. So he talks about the word resilience. The process of negotiating and managing and adapting to significant sources of stress or trauma. Assets and resources within the individuals, their life and environment facilitate this capacity for adaptation and bouncing back in the face of adversity. Across the life course, the experience or resilience will vary. So we found there's a bunch of factors that determine resilience, but these were the top 4. Hope and optimism, anti-inflammatory, sense of control. Again, the antidote to anxiety is control. When you lose control, you become even more anxious and angry. Positive outlook. It's not positive thinking. It's a can-do, moving forward, and also social connection. Turned out that social connection precipitates oxytocin. But look at chronic disease states, particularly chronic pain. People have lost hope. We have this new term called medical unexplained symptoms, which you lose hope. It's a death sentence. You've lost control, right? Nobody can tell you what's going on. It's hard to be positive. I call it the abyss. And then we lose social connection. So everything is made worse in the presence of chronic pain. So I have a term I call dynamic healing, where you look at the input, look at the coping skills, then you can address the output. So this is that same cat, about 12 years later. So with safety physiology, you have a metabolic state is anabolic, or actually putting supplies away. Your immune system is anti-inflammatory, we call it rest and digest, and people heal. So the essence of healing chronic disease, again, including chronic pain, is minimizing threat and maximizing safety. So I want to look at the 3 parts of it. Don't try to read this slide, please. I just want to give you an overview, reminding you that threat state is vasopressin, adrenaline, cortisol, is catabolic and pro-inflammatory cytokines. Safety is dopamine, oxytocin, serotonin, GABA drugs, growth hormone. It's anabolic and anti-inflammatory cytokines. So on the output, there's things you can do right now to lower your physiology. So one of them is just breath. So everybody just sit back in your chairs for a second. Just take a nice deep breath through your nose and let it out very slowly. And I want you to just listen to a sound. Drop your shoulders. So what you've done, you've actually stimulated your vagus nerve. We know that slow breathing stimulates the vagus nerve, breathing 6 to 10 breaths per minute. This started when I was 5 years old with migraine headaches. A cold compress to my forehead was remarkably helpful. Again, you're stimulating the 5th cranial nerve, which is close to the vagus nerve. The most anti-inflammatory organ or nerve in the body is the vagus nerve. Music. Lots of papers on music therapy. I don't know why it hasn't entered mainstream medicine more. It's well documented that music therapy works. You're stimulating the 8th cranial nerve, which again is close to the 10th nerve, which is the vagus nerve. The now vagal nerve stimulator, one of my friends, Les Aria, is now using a safe and sound protocol where threatening tones of music are filtered out, just earphones on your ears, and they're able to break into people's chronic disease states. Anger, frustrations is so effective people sometimes decompensate. But vagal nerve stimulation is going to be something you'll hear about a lot the next few years. So we talked about the input. Let's look at the state of the nervous system. So it's either calm or hypervigilant. So Howard talked about sleep. How many surgeons do you think ask patients about their sleep before they recommend major surgery? Anybody ever heard of that? So I'm not trying to throw my colleagues under the bus, by the way. I would have no knowledge of this unless I'd been through this entire process myself. I just didn't know. My colleagues don't know. We're not trained this way. So study out of Israel shows that insomnia causes chronic back pain, period. They did not find the reverse causation. So I found out the first thing in my work was sleep, and I noticed that, and I took a surgeon's approach. I went right to Ambien. It's a little controversial, I know, but it worked. Got people to sleep. Probably 20% of my patients went to pain-free just with better sleep. I'm going, okay, that's interesting. I still did not know much about chronic pain, but I did know that sleep was an issue. The magic number for physical activity, we all know that physical exercise is helpful. So we know it's also anti-inflammatory. It improves lots of things in your body. I also think it gives you a sense of control, which is important. But also, the magic number is 150 minutes a week of moderate exercise. That's the number. Lots of data on that. I also want to mention trauma therapy. You can't fix a broken brain. You have to rebuild it. And that's where I'm looking forward to your talk, is that people are broken. And the data on the ISDTP is very impressive, very critical, but you have to rebuild the brain. You can't fix it. Now, this is interesting about the input. So there's 2 questions. So what are you loading into it, and what are you hanging on to? Think about this for a second. So my wife and I have done workshops together. We did it with Fred Luskin. I've done it with my stepdaughter. And these workshops are profoundly impressive, but one thing we learned is don't discuss your pain, ever. I mean, where's your attention? So your attention's on the problem, not the solution. So from a neuroplasticity standpoint, you go in the wrong direction. So no discussing your pain, no grimacing, no complaining, no criticism, no giving unasked for advice, and no malicious gossip, ever. And people look at me and go, what do I talk about? I'm serious. It's amazing. Or we'd have people actually sneaking up behind the buildings to talk about their pain. It was like they're smoking in high school. It was amazing. So I think, be interested what the panel says, but I'm convinced that most people in chronic pain probably spend about 60% of their conscious hours on thinking about their pain. I did, 15 solid years, twice a week psychotherapy, trying everything possible. I became an epiphany addict. So it's hard not to do. But that is the one absolute thing I say to people in my office: when you walk out the door, done. And they're shocked. Mindfulness. So again, drop your shoulders for a second. Take a deep breath. Just listen to sounds for like 3 seconds. you switched sensory input. You went from racing thoughts to a different sensation. That's how I think it works. I mean, that's an orthopedic explanation, but you simply switch sensory input from racing thoughts to a different sensation. I call it active meditation. Expressive writing has been interesting. This is the only, I think most of us now use expressive writing. Dr. Pennybaker is known to a lot of us now, where he started the research in the 1980s. It's the one absolute starting point in healing. There's no shortcuts. There's a long story behind that, but we talked to Dr. Pennybaker in Seattle a few years ago. He said, look, Jamie, what's going on? Why does this work? I mean, it decreases viral load, it improves wound healing, it improves cardiovascular health, student performance, mood. It's unbelievable what it does. There's over 1,200 papers now that are well-done papers that document that it works. It is the only one necessary starting point. It's not the definitive solution, but you cannot cut this corner. And so he says, well, Jamie, how does this work? He goes, I don't know. But every paper shows that it works. Very powerful tool. I have done a lot of work on self-esteem. Most of our self-esteem is based on cognitive distortions. Should thinking, mind reading, labeling, perfectionism, etc. And again, they fire up the physiology. So recognizing cognitive distortions is actually sort of nice because they're not real in the first place. There's nothing you have to do. You just recognize them and go, okay, don't worry about it. So what are you loading into your brain is one question. 95% of people, though, in chronic pain are still angry at the situation or person that injured them in the first place. Guess who they're most angry at? Themselves. So when this book came into my practice about 10 years ago, Dr. Luskin has become a good friend of mine. We have dinner once a month, he's from Palo Alto, I'm in Oakland. And we talk about this all the time, but when his book came into my practice, people started to heal. I think Howard, you had sort of similar experience with Alan Abbas and the anger part of it. So again, I wasn't angry, I was tough, bring it on. So this book is a remarkably clear, simple book. This is when people started to heal. So winding this talk up, again, anxiety, it's a physiological state, very powerful, automatic, hardwired. It's become a big problem. This came out yesterday. For the first time, the U.S. Task Force proposes recommendations to screen for anxiety in adults. Well, guess what? Everybody has it. Anybody not have anxiety? So I want you to look at the slide. Again, don't try to read it. Just notice there's the input side. There's the nervous system, the output. I've listed some things on here. They'll be in the slide deck. The things that we do to change input, how we adjust the nervous system, and how we affect the output. Input, nervous system, output. So sustained threat physiology, anxiety, is the essence of chronic disease. Mental threats, the curse of consciousness, are actually the greatest issue. You cannot resolve chronic physical illness without addressing the mental aspects. So by addressing threat physiology, again, all three portals work. On a given day, it's different for given people. Addressing threat physiology optimizes the body's physiological profile to safety. Again, you can't get rid of threat physiology, you wouldn't survive. And what happens as you go to cues of safety, it actually prevents and solves many chronic conditions. That's why chronic pain and other symptoms are solvable. Don't know the data on chronic diseases yet, but we had one woman with ankylosing spondylitis. She's a physician, stopped the disease. Of course, didn't reverse the damage, but we sense that a lot of these chronic diseases can be halted with these tools. So it's cues of safety, optimize a patient's physiology, and remember that the most stressful stress is the stress you can't control, right? If you could control it, you would. So there's ways of processing stress in a way that minimize your impact on your nervous system. So dynamic healing, we're basically lowering the output physiology from fight or flight to safety. We're increasing the resiliency of the nervous system. Then we learn to efficiently and effectively process threat, the input. So all that being said, all the practitioners in this room, and I know a lot of you, do one thing. You have a great connection with your patients. Patients feel safe with you. You listen to them. They feel heard. So my contention right now in modern medicine, we've taken that away. To me, I'm going to use the word malpractice. So without that patient, physician, or provider connection, nothing else really works. You've got to have that. I mean, forget about the rest of it. You can do all sorts of interventions, even expressive writing or whatever, but you have to talk to your patients. You have to listen. So this is a very famous quote. Disease in man is never exactly the same as disease in an experimental animal. For in man, the disease at once affects and is affected by what we call the emotional life. Thus, a physician who attempts to take care of the patient while he neglects this factor is as unscientific as the investigator who neglects to control all the conditions that affect his or her experiment. So each person, stresses, coping skills, changes day to day. We're human beings. This was written in 1927 by Dr. Francis Peabody. So his final statement was, one of the essential qualities of the clinician is interest in humanity, for the secret of care is in caring for the patient. I know that's overstated, but if you put that in terms of physiology, it's actually very profound. So here you go. Essence of chronic disease, essence of healing. That's it. So I do a couple quick things here. I do some resources. This is my book. It reflects my journey out of chronic pain. I did put together a computer-based course called The Doc Journey, which is focused mostly on anxiety and mental pain. The app, my wife took it from me. She said, this is not an app. So it has things like juggling scarves, dancing kitties, cup songs, but it's about play. And it's a very entertaining educational app that's been released about 6 months ago. On Psychology Today, I have now over 1 million views on my Psychology Today blog. It's called Anxiety, Another Name for Pain. But I also want to honor a few people in this room. This is not a complete list, so please don't feel like you're left out by choice here. So we have SIRPA, of course, Alan Abbas, ISDDP, and Leon's going to talk about that more. The TMS Wiki is a great resource. Howard's done a lot of pioneering work, which has been great. The Curable app is very powerful. Crushing Doubt with Dan Ratner has been very powerful. My friend Les Aria, excellent pain psychologist in Sacramento, Menda. David Schechter's worked on a lot of different things with Think Away Your Pain and also the Psychological PPDA Association. These resources are here. They're available. Patients can access them. Clinicians can access them. So going back to Shivas Irons, this is life. Beautiful golf course, sunset. 'Tis a shame, 'tis a rotten shame, for if ye can enjoy the walking, you can probably enjoy the other times in your life when we're in between. And that's most of the time, wouldn't you say? Thank you.